Thanks everyone for taking the time to join. And yeah, I'm looking forward to talking with you about some things that we're thinking about. Oh, I'm giant on my, my own screen. Okay. Okay, I'm going to share my screen. Um, and forgive me because you'll see a little bit of the tippy top and the tippy bottom, but that helps me with my big screen. Okay, so today I'm going to be talking about challenges in estimating vaccine effectiveness against progression to severe disease. So thinking about different vaccine effect estimates with a focus on this progression part of the pipeline. So the motivating question is sort of one that came up during the COVID pandemic, but of course applies across a lot of different types of pathogens. So if vaccinated people can still get infected, what exactly is the vaccine doing for them, and sort of how do we quantify that benefit? And that came up a lot as a communications question when you still have a lot of breakthrough infections, and does that mean the vaccine does not work? And so communicating the other benefits of vaccines. So when we talk about the direct protection of vaccines, so the protection conferred to an individual, so setting aside for now any indirect protection, then we can think about the major benefits as being to one, first prevent infection, and then second to reduce the severity of the infection if infected. And so I like to think about it as a pipeline. I find this sort of progression model to be really helpful when thinking about this. And so, right, we start off with an infection, and then that has the opportunity to progress to disease, so symptomatic disease, and then on to a more severe form of disease. And and sort of at each step, there are opportunities for the immune system to intervene. So I'm going to distinguish between, and I'm not an immunologist, so I will say that up front. I'm happy to work with immunologists, so but bear with me if I oversimplify way more than is appropriate. But I think about sort of this first line of defense, this fast-acting adaptive immunity as the part of the immune system then that can prevent infection and the more mild symptoms of disease. But that's not the only opportunity that the immune system has to intervene. Even after infection is established, right, there are slower acting parts of the immune system that can contain the infection and prevent the infection, say, from spreading down into the lungs. And so we can think about that as sort of like a second line of defense or a slower acting adaptive immunity. So both of these are things that are activated by vaccines, but you can think about them as operating a little bit separately and both presenting an opportunity to confer infection. So when we think about estimating some of these direct effects, we can think about, we can define different outcomes of disease or different outcomes, public health outcomes of interest. So we can think about infection as being one type of outcome. We can think about disease as being another type of outcome. And the vaccine efficacy then is measuring that relative reduction in that outcome, comparing the vaccinated and unvaccinated individuals. So one minus this relative risk or hazard ratio or whatever. I'm just sort of speaking generally now. And I'm using the notation introduced by Betz Halloran, which uses S as denoting susceptibility to infection and SP as denoting disease, and you'll see why it's called SP in a second. And that's because it combines this benefit against infection with this benefit for reducing progression to disease. So we have this additional factor, which is how well the vaccine prevents progression to disease, which which conditions on infection. So it's among the sort of breakthrough infections, what is that risk of progressing to disease, and among these infections, among the unvaccinated, this risk of progressing to disease. And this VEP, this progression measure, think about it as providing a bridge between VES and VEP. So where VESP, sorry, did I say that right? Is a bridge between VES and VESP. So VESP represents this combined benefit from both this sort of first line part and the second line part, this infection part and this progression to disease part. Okay, and actually it can start to get more complex. So I gave, the example with kind of one step of infection and disease, but when we think about a disease progression pipeline, there are many different steps, and we've found it really helpful to add another layer, which is thinking about sort of even among the diseased, we're interested in progression to hospitalization. We may even go a step further and be interested in among the hospitalized progression to ICU or to death. And so basically at every step, there are these progression measures that connect each step with the next. And this is what we're sort of generally interested in is these progression measures, the connective tissue between these different steps. And we can tell that, right, that this is happening, right, that is this additional protection conferred because we know that vaccine efficacy across many different pathogens and vaccines varies by the severity of the outcome. So depending on if you're talking about sort of any infection or mild symptoms, hospitalization, ICU admission, death, we see that vaccine efficacy gets higher as the severity of the outcome increases. So basically at each step, there's this additional possibility for this benefit to be conferred, this progression benefit to kick in. And this is an example from a review paper, a short review paper that we wrote that, just looks at across a few different pathogen examples. And you can see, for example, influenza, as the severity of the disease increases, right, you see this evidence of this higher protection against the more severe form of the disease. Okay. So if we want, so we have these measures, right? We have protection against disease of any severity. We have protection against moderate or severe disease. Then we want to be able to, we're interested in being able to infer how strong is this protection, this progression measure. And so what you'll see as this talk progresses is that we don't really have a lot of approaches for how to sort of isolate this, or certainly not very good approaches. Um, the most basic way is that you can infer it because if you look at how if you look at like I said, VEP is kind of this connective tissue that connects how well the vaccine prevents infection and how well the vaccine prevents disease. Um, and so you can solve for VEP as this by dividing this protection against disease and the protection against infection. And it's like a little example. I mean, typically we'll have, may have quite low protection against infection, higher protection against disease. So in this little example, actually you have this additional benefit of 50%. So the VEP is having this additional benefit of 50%. So it's not much more complicated than that. You're just dividing these to get this middle part, this bridge. Okay. So like Ravi said, I mean, during the pandemic, in addition to kind of the scientific work, was also involved in scientific communications and found that communicating this progression benefit was hard for many reasons. And I think actually probably among the more effective approaches was sort of like the pulling from the flu world, right? And this sort of, I really like this flu vaccine can take a flu vaccine can take flu from wild to mild, and they give lots of, cute little bears or cute little dogs. And this is a nice campaign, right, that is really highlighting the progression benefit. So it's not saying that it can necessarily prevent the mild, but it's saying that you're much less likely to have the wild. Unfortunately, this campaign has been sunsetted. I'm not quite sure that, with the administration change, whether this will continue to be used in this current season, but it was sort of abruptly ended last year. But I think that this type of messaging is quite good. But it's underscored by these sort of this evidence of this VEP. Okay. So in addition, it's also something that in research studies that people are, seek to estimate. We've been working a bit with the Ivy network, which is one of the studies, the CDC run studies that looks at uh, severe respiratory virus infection. And this is one of this group's papers from 2021. And it was published in JAMA, and it was looking at the association between mRNA vaccination and COVID-19 hospitalization and disease severity. So it's kind of two parts to this study. This is a study looking at it's a test negative design study looking at individuals hospitalized with COVID-19. And then among those individuals, it was looking at their severity outcomes. So progression to ICU admission, their need for mechanical ventilation, death. So those sort of even among this group of hospitalized patients, what that next level of severity was. And so you'll see estimates like so here this what they compared. Um, they were looking at among their fully vaccinated case patients. Among their total breakthrough cases. So these are the hospitalized cases that were hospitalized kind of despite vaccination. What number of them progressed to death or invasive mechanical ventilation? And then among the unvaccinated hospitalized patients, which is already a much bigger number, right? But then what fraction of them progressed on to death or invasive mechanical ventilation? And one of the statistics they report is this adjusted odds ratio. So they adjusted for some covariates. But it gives you evidence that disease progression. So, you can see like, about half of these patients are progressing as 12% as compared to 25%. So about half as likely to progress onto death or invasive mechanical ventilation. And it's sort of interpreted disease progression to critical illness after hospital admission was associated with a lower likelihood of vaccination among a population representing typical hospitalized patients in the US. So I just want to make the point, right, that I'm going to be talking about this problem in a very general sense, in that, I sort of here we're giving this example of, I'm thinking about this progression pipeline, but where we focus our attention, I'm a little agnostic to that. So it will depend on the design of the study and the population that they're focusing on. Here we have an example of hospitalization and progression onto ICU admission or mechanical ventilation. But there are other examples where the progression we're looking at is from some sort of medically attended disease onto hospitalization, or from infection onto hospitalization. Okay, so all of these, I think what's key is that all of these are looking at conditional on one step of this pipeline, that risk of progression to the next step of that pipeline. Okay, but sort of our existing approaches have limitations, and I want to flag a few that sort of we see that. So first of all, there's something special about particularly these early breakthrough cases. So when you think about who are the people who are becoming hospitalized despite vaccination, it's not sort of an average vaccinee, right? They're disproportionately vulnerable in that they're older, more likely to be immunocompromised. And these cases are naturally going to shape sort of early estimates of VEP. So already it's like we're not really comparing apples to apples here. Um, and it sort of, the way that we've approached this problem, we've sort of been circling around it. And one of the things that it interested me is this idea is VEP measuring kind of what we think it's measuring? Is it reflecting this biologically meaningful quantity? Um, and and what made me think about it was a pattern sort of observed for COVID-19 vaccines that you observe across other, with other types of respiratory virus vaccines, where you have this very fast waning of protection against infection, but more durable level of protection against severe disease. Um, what does this mean about VEP? Does this mean that so if you think about how this effect times this effect equals this, if this is declining, but this is staying stable, does this mean that your protection against um, your progression protection, that second line of protection, is increasing? So can we interpret that as increasing? So here's sort of an example. So this is drawn from a paper from Daniel Lin and colleagues looking at data from North Carolina, but represents sort of a typical curve in that we see this early period of increase in vaccine effectiveness. This is looking at months since the first dose in protection, but then that starts to sort of that wanes over time, whereas protection against hospitalization ends up being more stable. And what we what we decided to do is sort of just look at this data and sort of what if you just look at this crude estimate of um, VEP that is implied by the difference between these curves, just as that connective tissue between these curves. It actually, right, you end up getting something that it starts off almost very low, almost even negative, and then sharply increases over time. So it's just trying to grapple with whether this is sort of a represents whether this VEP, whether we can interpret it as a quantity, a meaningful quantity, or certainly as something that an increase over time represents a real biological strengthening, as we would say with other things that increase over time. Um, so the way we approach that, so I was working with my colleague Veronica Zarnitsnia, who's at Emory School of Medicine, she's an immunologist and mathematical modeler. And we built a sort of a very simple, a minimal mathematical model where we assumed that the individual level protection against progression, this VEP, was constant, but wanted to see, you know, where in the model space you could observe, despite this being constant, where does it appear to rise over time? And what we found is that this can occur when you have a population heterogeneity, basically, when you have a vulnerable subgroup that has weak protection against both infection and progression. And let me explain. Well, first, let me just sort of so we searched this space and we found, this sort of part of the parameter space where this dynamic could occur. And like I said, I mean, the major feature was the existence of kind of at least two groups where there's population heterogeneity, where you have one group that has, kind of strong protection and one group with weak protection. So this is extreme in that it's sort of no protection, but you can still get the same basic shape even if this is not zero, it's just lower. So we explored it with a little more overlap between the groups as well. And this only represents a small fraction of the population. Like I said before, we assumed that the protection against progression was constant over time, and then we assumed that protection against infection starts off high, but wanes over time. Um, and each group has some fraction vaccinated, and basically you can just infer over time this level of um, vaccine protection by doing kind of just like what the study did in that JAMA example. I mean, just looking at what fraction of cases are sort of progressing for the vaccinated cases and the unvaccinated cases here just at each time t. And we were able to, basically find these trajectories where VEP appears to increase. And the explanation, I mean, that we found was that the breakthrough early on, these breakthrough cases, right, are not just sort of the average vaccinee, kind of like I said before. They were predominantly among the vulnerable who are going to have weak protection against infection, but then also weaker protection against progression. Meanwhile, the unvaccinated cases have a different composition. They're more evenly spread across the general or immunocompetent population. And over time, particularly as this first line of infection wanes, then we start to see a shift in that you have more and more breakthrough vaccination cases among people with good progression protection. So this starts to increase. So the observed VEP appears to rise even though individual level VEP is constant. So, I mean, the reason is clearly has to do with this sort of we're conditioning on this post-vaccination outcome of infection. And that means that these groups are not directly comparable. So the infected vaccinated do not have the same distribution, do not have the same characteristics as the infected unvaccinated. And this is not a new problem. I mean, I think that there's been a lot of work in the HIV, or well, I wouldn't say a lot of work, but there's been a good amount of work in the HIV arena, looking at, for example, viral load among breakthrough vaccinated infections for HIV vaccines and sort of in studies. And so going back to sort of 2006, yeah, there's papers from Hudgens and Halloran, and also Peter Gilbert. And so thinking about this type of problem, um, but it's manifesting here with like you know, in this with this time element too. I think this is another particular feature of this is we have this element of time and waning. Okay. And so it underscores the challenges in interpreting VEP in both randomized and observational studies. So I think one of the key features that, what we've been thinking about a lot lately is that um, although we can think about these steps as sort of this fast-acting adaptive immunity and this slow-acting adaptive immunity as separate steps in this protection pipeline, um, that there is sort of an underlying latent variable which relates to the strength of the immune system. So these are not independent steps, and there are individuals who have stronger immune systems that are going to exert themselves kind of at both steps, in contrast to individuals who are going to have weaker immune systems that are going to have sort of lower protection at both steps. So there's heterogeneity at each step, but there's also correlation in that heterogeneity. And I think that is what sort of particularly presents a challenge here when you're conditioning on this first step and looking at progression to the second step. Okay, and we can see evidence of this, both this heterogeneity and this correlation. If I look back at that same study of hospitalized patients in JAMA, where they're looking at mRNA vaccination and COVID-19 hospitalization and disease severity. So like I said, the first part of the study is a test negative study looking at the outcome of COVID-19 hospitalization. And they include a lot of subgroup estimates. I'll call your attention just to one. So this is protection against hospitalization by subgroup. And they're looking here by immunocompromising condition and seeing a bit, a large amount of effect modification by immunostatus. And so with much lower protection among the immunocompromised than among the immunocompetent. So that's that first. So in this example, I'm calling this the first line of protection. But this is sort of the first step in that pipeline. And then in this study, they also estimate the progression outcome among each subgroup. And we also see here this it's not quite as clear because the numbers end up being smaller, but differences in that the immunocompromised also have weaker protection against progression to ICU given hospitalization by subgroup. So there is evidence of this correlation and how that can affect. And so, when we're thinking about sort of these overall estimates, becomes sort of less clear what we're measuring. Okay, so as we think about kind of ways to address the limitations of VEP, try to approach it with different settings in mind and the different use cases. So why do we want to study VEP? Why do we want to estimate VEP? One role where VEP appears is in parameterizing vaccine impact models. So these are models where you put in characteristics of the vaccine and of the population, and under different uptake scenarios, under different performance scenarios, estimate some output like the total number of people being hospitalized or in the ICU. And so it can give you like cost effectiveness or, but there's different sort of these population level models that allow you to measure these overall benefits. I think another role is when we think about vaccine development is being able to separate out this sort of first line of protection, second line of protection, where that may vary across different vaccines that have different mechanisms. And then, as before, kind of this communicating the value of vaccines, so either at an individual or population level. So let me kind of briefly go through these one by one. So as an example of vaccine impact modeling, this is just one example looking at the potential clinical impact and cost effectiveness of the updated COVID-19 vaccine for a particular season. And you can see it's like these are the types of models that underscore these infographics, which show, this fall campaign is estimated to reduce symptomatic infections by this much, hospitalizations by this much, deaths by this much. And so these numbers are generated through a vaccine impact model. And the way that that these are, structured is just by sort of solving, you need to, I cut out a slide, maybe I shouldn't have, but the way that these sort of mechanistic models work is you model people getting infected, and then once they're infected, they can progress through stochastically through this pipeline of outcomes, and their vaccination status will impact their probability of progressing through these different outcomes. And but I wanted to make the point that the VE they're using, is like this is the VE that, this VE1 is this first line, VE2 is the second line, and it's being solved for, in this way that, we did before, where you have the sort of population average. So this is one way that we want to get good estimates of these second line protection in order to inform these models. And intuitively, it makes sense that it does matter to kind of get these things right, in the sense that you want to, where you have a group that is both has high protection, first and second line protection, they're like doubly protected. Whereas if you have groups that have weak first and second line protection, they're like doubly at risk. And so when you think about the distribution of population outcomes. It's like there's sort of less of a return here when someone is doubly protected, versus if you had a vaccine that had more even protection across the population. The other thing is sort of insight on the vaccine mechanism, and this is just my crudely drawn picture, but just to show, right, that as we think about different types of vaccine models, like intramuscular vaccines or intranasal vaccines, where intranasal vaccines being more focused on trying to activate a higher level of protection against infection, um, then right we then it's helpful to be able to know whether a high level of disease protection is due to sort of low VES and high VEP, or is it sort of moderate VES and moderate VEP? Um, and then we've also been thinking about sort of communicating the value of vaccines and the different use cases. Um, and so one example I sort of can think about is a prevention message. So if you get vaccinated, your risk of infection drops. And if you do get infected, your chance of severe disease is much lower. So we want to be able to sort of say how much lower. This is sort of this population level VEP. And this is actually slightly different from another estimand, which is sort of after infection. Even though you became infected, vaccination still reduces your risk of progressing to severe illness. So this is sort of like among the breakthroughs, what is that conditional benefit for reducing the progression outcome? So it's just to say that there are slightly different measures, and they're going to require slightly different estimands. So sort of as we think about, so I've flagged a lot of questions, not a ton of answers. I'll sort of tell you the way we're thinking about this problem. Um, so first is just uh, as much as possible, trying to represent data more as like a pipeline. So like in the vaccine impact modeling, getting more subgroup specific estimates that then we can link together subgroup specific VES, subgroup specific VEP, um, and being able to connect people in a pipeline that really represents that's going to naturally capture their heterogeneity and also that correlation that goes between those. Um, and also, characterizing the the amount of correlation as another feature of the problem between the lines of protection. So working with Veronica Zarnitsia, we've also been thinking about the immunology that actually governs the first line of protection and how that wanes, and the immunology governing the second line of protection and how that wanes and how that can signal to us um, ways we can approach the problem. So I'm being a little vague here, but and then causal inference, so the major issue with the conditional outcome is it's not a causally valid outcome in that it's comparing two populations that are not directly comparable because you've conditioned on this sort of post-vaccination outcome of this first step. And so one approach is principal stratification. And so, the major challenge, right, is that you have this among the unvaccinated, you have this group that can be infected, whereas among the vaccinated, some of them will have their infection averted or prevented. And when you go to compare these groups, right, like if you think about this being a more vulnerable group, you can't directly they're going to have different characteristics than this group, which is sort of a more of a cross section of the population. So with principal stratification, so one approach is to define like a doomed stratum. So that's going to be the group that can be infected at a particular time, basically they're the group that no matter what would be infected, whether vaccinated or not. And so I've been working with folks who are better at causal inference than me, some folks at Emory, and then defining sort of the assumptions that are needed to make these types of values estimable, but also in order to, where you can't infer it all, it's some sensitivity analyses, at least to put some bounds on those values. So this gives you kind of one of these estimands. This kind of gives you this, even though you became infected, right? It gives you this doomed one, but it doesn't give you actually this wider before vaccination prevention population level benefit. Okay. So that's kind of another area we're working on. So I will wrap up just to say that, right, I just want to call attention to, right, VEP and these progression measures as not being straightforward, and not obviously giving back sort of a biologically meaningful quantity. It it can, for example, can appear to change or increase over time, even if true protection is constant, and which just ends up being a product of these selection mechanisms due to this conditioning on this first step. Um, Being a breakthrough, I think carries some information with it, right? It's special, so naturally that group is going to be enriched for a more vulnerable population, and that selection tells us something important about heterogeneity in the vaccine response. And that moving forward, we need more methods that capture both the protection and the selection. And so we're integrating immunology, causal inference, and in the absence of those, encouraging a lot of subgroup specific estimation, so that the models that we fill in can have that level of detail. Okay, so this work's been supported by Emory SIDMath. So Emory SIDMath as our Center for Infectious Disease Modeling and Analytics training hub, and this is sort of one of the multiple areas that we work in, along with wastewater epi, social contact patterns, and machine learning. And another activity of SIDMath that every time I talk to anyone, I have to mention is just that I co-direct the SISMID, the Summer Institute for Statistics and Modeling in Infectious Diseases. This is a summer program, long-running summer program that started by my mentor, Betts Halloran at University of Washington, and now it has been at Emory for 2 summers. So this is for this past summer, but we'll be running it again this coming summer. And we'll have a mix of in-person and online short courses. We're also sort of setting the schedule now. If there's a topic you really want to learn about, now's a good time to reach out. But so with that, yeah, happy to switch over to take questions.